is going beyond the like CTO procedure, like calcified procedure, rota procedure, IVL procedure. Many kind of patient refuse to see a very advanced kind of difficult and bifurcation procedure. So ultimately, all this procedure is a kind of lead to dissection or perforation or complication. As per this slide, define the definition of coronary perforation. It is perforation is defined as evidence of extravasation of contrast medium or blood from the coronary artery during or following percutaneous intervention. So more or less, it will the incidence between 0.1 to 3%, and it will lead to morbidity and mortality. Mostly, it will deteriorate the patient from like cardiogenic shock, on-table procedure-related MI, or it will lead to tamponade and patient going to sudden cardiac arrest and there. So it is not like to open up the vessel and dilate and well it out all the hardwire or device, but only thing keep in mind to what is the end result and what is the procedure related, any adversity is there or not. So we have to look for final shoot for the procedure, like we using many of times soft wire, but in the case of hard lesion we use the hard wire, hydrophilic coated polymer jacket wire, steel tip guide wire. Most commonly we use kind of overinflation. We have to make sure that vessel size according to that we choose balloon and 1/1 pressure is there. If you overinflate, it will lead to internal tear and lead to myocardial hematoma, intraMyocardial hematoma, or more or less it will lead to dissection and perforation. So oversized balloon and stent, high pressure, if you go to the 12 or 14 millimeter regime, a small balloon, it's okay. If you go beyond the certain level of that not tolerant, it will lead to ultimately the perforation. Stenting, tapering, or small diameter vessel and atherectomy device like rotor device, IVL device. So these are the
regarding positive, the way patient gets cerebral aneurysm. Do you have any term like coronary artery aneurysm and bleed?
Yes, coronary artery aneurysm, electric vessel. Bleed is not there, but thrombus and inflammation is there. Many of the acute setting, the thrombotic part is there. So at that place we using thrombosuction and cover stent. So these are the slide present the acute complication of PCI. We can see cardiac and non-cardiac. So if you go through the non-cardiac part, there is a vascular, either radial or femoral related hematoma or a kind of complication. Thrombus may dislodge into the distal vessel and lead to embolic phenomena. Maybe we use contrast related nephrotoxicity and local radiation hazards. So we are going through the cardiac and coronary and non-coronary. Non-coronary related hypotension, procedure related MI, arrhythmia or tamponade. So many focus in this part coronary perforation. Either it is the main vessel involved, either it is the side vessel or distal branch involved, or either it is the collateral, either it is a septal collateral or epicardial collateral. So acute vessel closure may be more or less every cardiologist can follow this. So these are the type 1, 2 and 3 types of disease classification for coronary perforation. Only the crater, these are the extraluminal like craters, only the small pinch is there. It is not extravasation, it is a kind of mild perforation and not need to worry because it will, we just need to observe this and later on if patient getting effusion or patient getting more dynamic deterioration, then we will decide further plan of action. Type 1 is extraluminal crater without extravasation, otherwise benign in nature. Type 2 is pericardial or myocardial blast without contrast, just extravasation. It is less than 1 millimeter from here to here, less than 1 millimeter exit port. And type 3 is from the pericardium side, extravasation. It will lead to coronary sinus or pericardium or LV cavity. So perforation in anatomically chamber, it is not always the benign course. It will progress and need to tackle this situation as much as early. So other classification apart from English classification, these are Foucault-Tommy and Kinney classification. Universally, this is not used, but only used Kinney's classification. This only type 1 and type 2, they define Foucault-Tommy as epicardial staining without extravasation. And type 2 is staining with contrast extravasation. Visible Z is always there. And Kinney is myocardial staining without extravasation. And type 2 is extravasation into pericardial sinus of cardiac chamber. So these are the types of coronary perforation that we have to look for. Either it is large vessel involvement from proximal segment, mid segment, distal vessel perforation, this is the distal branch, collateral, this is the septal collateral, and epicardial collateral. So after the procedure has been completed, and then we disengage the, before we disengage the guide, and we have to check the final shoot for any blushing or extravasation dye is there or not. So firstly evaluate the patient, hemodynamic parameter we have to check, and if we are like more or less we found patient in trouble, then call for help, or a bystander or a CVTS surgeon has to inform. We look for the hemodynamic of patient. If patient has been deteriorated, then prepare for is there, embolization is there, or perforation is there. So these are the universal algorithm. Firstly, what we have to do, if we found that after the procedure has been completed, we found that perforation is there, either it is type 1, 2 or 3. First and foremost step is to inflate the balloon at the site of perforation or before proximal to the perforation. Inflate the balloon to occlude the vessel, like we have found perforation here. So we have to insert the balloon through this guide wire and inflate the balloon at least for 15 to 20 minutes. Repeated 2 to 3 times has to be done, and if the perforation seat itself, then leave it and watchful for observation for tamponade error. Intravenous fluid or vasopressor need to be stopped. Inotropic support and fluid resuscitation. Backup for pericardicentesis and notified surgery. So this algorithm, we have to look step by step. Persistent extravasation is there? No. Then and then only monitor the patient. If yes, then what is the underlying cause? Look for the distal vessel involved or proximal vessel involved. I mean large vessel involved. So if large vessel is involved, then definitely you have to put tower stent. If this technique prolonged balloon inflection and dissection technique is the other one to seal the large vessel perforation. If getting distal vessel perforation, then these are the options: OA, FED, or distal embolization technique. A cover stent over the perforated branch. If continued extravasation, then reversal for the anticoagulation has to be done. And ultimately, if anything couldn't help, then definitely go for surgery. So majority of time, 75% complication in coronary intervention, like CTO and all these atherectomy device will lead to proximal or main vessel perforation. Rest of the 25% is collateral and distal vessel. So again, this we firstly focus on to the large vessel perforation. How to treat the large vessel coronary perforation? First and foremost thing, you have to keep calm yourself, and we need to first inflate the balloon at the side of proximal or at the side of perforation. Make sure that ratio of balloon is to the vessel is 1:1. 1:1 balloon diameter at low atmospheric pressure. Don't do high atmospheric pressure balloon at the site of perforation. Only 1:1 side of balloon and low atmospheric pressure for 10 to 15 minutes. Majority time it will seal the perforation. Do not reverse anticoagulation. If a wire or any balloon is inside the vessel, and do not reverse and do not give protamine, because it will lead to thrombogenicity and will lead to thrombus, and you will stuck into this. Along with this, you have to see the hemodynamics of patient, need to inotropic support by either IBP or LV assisted device or pericardial surgery. So proximally occlude the vessel. These are the first foremost steps. And large vessel perforation. So, what are the causes of large vessel perforation? These are the causes. Like we use the oversized stent sonography we observe many of time we observe the different projection view. Some intra-observer variation which look like me to 2.5 mm vessel, someone has to 3 mm vessel. We put 3 mm stent and it will lead to oversized stent and balloon will lead to rupture. And if you are going to the hard high pressure balloon and some kind of severe calcification is there, balloon rupture, atherectomy, wire, microcatheter balloon. These are the iatrogenic hard wire catheter. Either we choosing the high pressure or either we choosing to the oversized stent balloon and this dividing like poses. So what we have to do is treatment the balloon inflation first and second cover stent. Balloon inflation, as I already mentioned, is the site of perforation or proximal to the side, low atmospheric pressure, 15 to 20 minutes. Second thing we can do for large vessel, we put a cover stent. So two techniques is there, block and deliver and ping pong guide. Block and deliver means you have to block that site or perforation site and deliver the cover stent. And ping pong, it will engage the two guiding catheter at the same time. Another is dissection technique and for finally surgery. So these are the cover stent delivery. First thing, if we found that small vessel perforation, go for balloon. Large vessel perforation, first step is to go with the balloon. And if things is not in control, and then go for cover stent. Block and delivery. So these are the guiding. Things right from the right ostium. So we have to. These are the two wires, guiding wires. So in one wire, these are the balloon inflation is there. Balloon. So okay, these are the first slide. It shows that this wire is crossing through the lesion. These are perforated sites. So what we have to do? We have to insert a balloon. At that time, low pressure balloon. We have to look for sealing a perforation. Wait 2 to 3 times. We have to do the same and repeat angiogram to be done. And then again, we have to see if perforation is there. Then we have to insert a second wire across to this perforation. Balloon transiently deflate to cross the second wire, and after the crossing the second wire, we have to again inflate and deflate, and we have to bail out this. And from this second wire, we have inserted. We insert a cover stent from there. We have withdrawn the first guide wire and balloon, insert the second wire, cover stent over there, and need to cover stent deploy post diagram, and then hemostasis achieved. So these are the block and delivery. First wire we have to block at that side, and again bail out and immediately insert the second wire and cover stent to see the perforation. These are the second technique, ping pong technique, because it will use two guide wire. So these are the perforation side. So during that technique, we inflate the balloon, but it couldn't stop the bleeding. So first we have to disengage from this point to make entry of second guiding catheter. So after the inserting, we have to inflate and deflate, and again deflate to insert this second guide wire and this cover stent. And after insertion, we have to put like the first hardware or equipment, and then cover stent is deployed, and then perforation is sealed. So for large vessel, it is reasonable to put a cover stent at this side. Mainly we use polytetrafluoroethylene cover stent. Large vessel perforation, cover stent, graft master stent, and PK papyrus single layer stent. These are the graft master we use almost frequently in India in our institute. So it is a sandwich type of design. Polytetrafluoroethylene, 6 frames mainly use femoral or many. And these are the PK papyrus single stand design. So these are the guiding which we use. And another is dissection technique. Many of the time, what happens? We enter into the CTO lesion and we enter wire through the false lumen. So we have to make a track, go to the distally of the lesion and create a false lumen, and again inflate the balloon and make a true lumen. Again recross the wire through the true lumen, and then inflate the, and then cover stent should be there. So this is a dissection technique, and rest for large vessel perforation last step is to surgery. If patient is getting deteriorated, then surgeon has to be informed and advised. Okay, after completing this large vessel perforation, we are going to discuss small vessel perforation. In large vessel, falsified or tube CT, atherectomy device, or more or less hardware related. In small vessel, the same way advancement of guide wire, balloon or microcatheter into a distal small branch, polymation, steel polymer jacket wire, wire is majority time we focus on to the lesion. We polymize and shutter in that particular section of where we have to put a stand or push dilate. We don't see the wire as distally where actually it lies. So we have to keep the monitor where the wire, because many of time these hard wire or polymer coating wire lead to perforation and distal side. So what we have to do for prevention, meticulously attention to distal guide wire position. Frequently we have to check the status of our distal guide or distal wire. Use the soft workhorse wire for equipment delivery. Soft wire, we can once they insert the hardware and then change with the soft wire. So this kind of workhorse wire, soft wire like floppy wire and trapping technique. So again, same. What are the distal vessel perforation? What we can do? We can embolize with fade, coil, or cover stand if the thing is not under control. Small vessel perforation, balloon inflation. We have to balloon inflate proximally at the site of lesion to seal the vessel. It will temporarily lead to ischemia because of fluid shutdown and the distal vessel patient will complain of pain. But it will get ischemia or necrosis that vessel, but we need to close the vessel. Another is embolization of the fat, coil or other gel form thrombus. And third thing is cover stand across the origin of perforated branch. And fourth thing is surgery. Fat, like adipose tissue or it is a human origin, low in cost, easily available. Fat it will lead to atherogenicity and lead to population. So it will seal the coil. It is readily available. Coil. This is the. These are the coil small vessel perforation, pushable coil. These are the coil with a packable shape, and another is the straight shape, vortex, and it easily fills the distal segment to block the vessel at that side of perforation. So these are the delivery, micro delivery system is there. So what is, these are the microcatheter. So any kind of foreign material, either is thread or gel or any kind of thread or whatever the material you using for packing distal vessel perforation, we have to introduce through this, and these are the pushing wire. So push to inward, and then again wire have to be crossed to make sure that it will distally embolize to seal the vessel. So another is thrombin, gel form, wire fragment, microbeads, thrombus. These are the technique to seal the distal vessel where we can't put a stand, cover stand. So these are the fade and coil differentiation, comparison. So visibility fade in fluoro, we cannot make a control. Coil is a metallic particle, we can see easily on fluoro. So delivery coiling is easy as compared to fade. Catheter, any type of microcatheter we can use for fat embolization, and for coil it is a different size. We have to use a larger microcatheter. Availability is often limited. Fat or any kind of coil material we have to see universally. Cost is high in coil. So these are the, again going through the same slide: platinum, microcoil, thrombin, autologous clot, subcutaneous tissue, gelatin, and alcohol for polyvinyl. And these are the theoretical aspects. Mainly stainless steel or platinum is there to distal coronary perforation seal. So during that perforation seal, either distal or proximal or collateral, these are the medication we have to use at that time: sedative, dilator, contrast, anticoagulant, antiplatelet, vasopressin, antiferritin, to maintain the hemodynamics of the patient. If things things are not getting controlled, then we have to reverse the impairing effect as per the ACT value. Protamine we have to give one for kind of treatment and make sure that high wire is coming out. This again, this summarize the slide. Perforation. First, we have to do balloon inflation at the site of perforation. Again, assess the hemodynamic evaluation of patient. If stable, leave it. And if unstable, then again start to resuscitate the patient. And if persistent bleeding is there, make sure proximal vessel is perforated, distal vessel is perforated, whichever kind of vessel is involved. If it is bifurcation, go for surgery. No bifurcation, cover stent. If it is proximal, then first directly go for cover stent. Another option is always available. If it is distal, then go in thrombin or distal embolization. These are the articles showing novel approach for coronary perforation, absorbable suture, embolization, distal coronary perforation.
So what was that drug list? So you give vasodilator locally or systematically?
Locally.
Locally. Yes.
So always strategy depend upon the severity, hemodynamicity of patient, and what are the site of perforation and bleeding. These are the Phillips classification type 1, type 2. Type 1 is always benign, leave it and watch for observation. If Coronary develop or if effusion is there, then need to recheck the shoe patient, shift again and the evaluation where the site is bleeding. Type 2 or type 3, majority of cases it will lead to make patient in trouble. We have to stop bleeding at the site of Coronary. So emergency surgery is always need to, is class 3 reported that 60 to 70% go for surgery. And what we have to prevent for ideally best way is to tackle this perforation is not to make a perforation. So we have to careful for this. ACT optimum in GP2B3A inhibitor, unfractionated heparin, protamine, we have to reversal. Otherwise, we were using direct forming inhibitor, need to be because short acting. Multiple view, we have to make sure, and dual injection, dual catheter, some kind of wire we have to use, intracoronary imaging need to rule out, and wire to confirm true lumen or false lumen, we have to make sure. And side branch or collateral, many of time we need not do any kind of life-threatening bleed, kind of. Again, the same storytelling that need to reverse the anticoagulants, putting the cover stent, and make sure of distal thrombo embolization device, and again surgery is the last option. Type 4 perforation need to. So these are the theoretical aspect. Only after the perforation we have to make sure distally or proximally. So only two options is there, either cover stent or either distal embolization, coiling or thrombin, whatever available option at that time, period of time, and last option is surgery is always there. So these are the 3 or 4 cases recently we go through this. These are the female of 65 years of age. She was on anti-anginal treatment, guideline directed. Still she has having effort angina, CABG in 5 years back. She was done, it shows triple vessel disease with tight lesion calcified in osteoproximal LCX. So we decided to deal with the rota with TPM support. So what we have found is this is TPM support. These are the calcified lesions. So with the rota pro we deal with this calcium wire. These are the tortuosity of vessel. The vessels angulation is sharp. Multiple attempt with rota found that vessel is perforated, Phillips type 3. We need to cover at that time immediately. Rota size is 1.5 to 2.
So there was a CTO.
Yeah, it was not CTO, it was subtotal calcified.
So how much percentage were accrued?
It was around 90.
So do you think it was a culprit for a rapid angina?
thing we had checked the previous angiography of this patient. Which
There was a new lesion, that's why you.
So in last time the perforation is almost flushing into the pericardial cavity is freely.
So don't you think here that perfusion study would have been helpful?
Yes.
What was the rejection fraction?
Ejection fraction is fair and 50%.
ECG echo were insignificant.
Yes.
तो आधे का इन सड़क तो पकड़ी हुए
ECG and echo were not significant. TMT was done,
TMT was
not done.
directly patient admitted for HIKU. We were the new service developed.
So this must not be a MA patient, right?
No, this is a paid patient.
Paid
We are only
patient.
using paid patient. Perfusion study is
But
beneficial
on
in case of
what,
CM.
I am not able to understand on what basis you went for angio directly.
Right? TMT effort angiogenesis from TMT.
No TNG, no orbital stress echo, nothing, direct angio. And angio કરી લીધો તો આ lesion ખોલવા જવાની ને જરૂર પડી.
Angio is gold standard, isn't it?
No, basically first we have to non-invasive DSC or of TMT. But
Homokem direct.
because having the history of
લાલજી ભાઈ ટ્રીટમેન્ટ નું કોમ્પ્લિકેશન ડિસ્કસ કરતા હોય ને ત્યારે કેસ હંમેશા આઈડિયલ બતાવે. ટ્રીટમેન્ટ જ ખોટી કરીએ તો એના કોમ્પ્લિકેશન બતાવવા જાવ તો વધારે માર પડે.
no sir, in guideline directed maximum tolerable therapy there.
What was the dose? વાઝોડાયલેટર શું ચાલે?
પણ એ ગાઈડલાઈનમાં TMT કરવાનું નથી આવતું.
But patient was not able to perform TMT.
તમે
Very obesity and
GDMT લખ્યું તો હાઇડ્રોલાઇસિસ ચાલતી હતી?
yes sir, Nicoral monotrate trimetallate.
પછી શું કર્યું એમાં?
Okay, sir. It will be large vessel perforation is there, LCH. So need to cover stand, put a cover stand immediately.
ક્યાં corporation કઈ આગળ?
ફુવારો છૂટો છે?
So we using cutting balloon at that time, and after the rota and high inflation pressure, it will rupture the field area of
Who done the treatment and who done the treatment of complication?
this.
બલૂન કોણે નાખ્યું હતું અને પછી પરફોરેટ છે પછી કોણે પછી ક્લિયર કર્યું?
These are the side of perforation. He was case was handled by Costa. These are the small and again we assess the echo for pericarditis. These are the site of completely here the LCH. These are the flush into the pericardium. And we put cover stand at this side. Again the ostium is missed, so we put another stand from LA to LCH. You have to see this cover graph. We assess this patient frequently, an hourly echo, and there is no any infusion. That
Diffusion now available બને?
there is no ongoing progressive
Progressive.
patient, no deteriorating, no anything. These are the case two again, patient, this was case at Surat Baker Institute. Evolved MI presented with inferior MI, 50-year male having history of diabetes and hypertension, taken for CAG, and RCA lesion was complete. So we have to do the covers, we have to put a stent for proximal to distal, and our wire is in distal branch, so it will lead to perforation distally. So we did a balloon at the site of proximal to the vessel. Distal vessel is not more in area of coverage, so we inflate a balloon for 50 or 20 minutes, 3 or more times, then it will seal this perforation.
So how much evolved the inferior wall MI was?
Evolved, it was more than 24.
More than 24. What was the ejection fraction?
So
Ejection fraction कितना था?
ejection fraction 45.
So was that procedure needed again?
No, this was a class 3 indication. If within
Class 3 indication में हाथ से करें काम आउट करो प्रभु.
nowadays,
What nowadays? Inferior wall MI માં આવું કશું ઉખાડી દેવાનું ના હોય. તમે લેટ આવે છે તોય તમે
but it will happen at any point of time. If emergency procedure, rescue procedure, we undergo complication, we cannot predict.
Of course, but I need to argue against that there was PTCA was needed or not.
PTCS, if patient is thrombolized, then put on antiplatelet. Otherwise, non-thrombolized, EVOL-MI is there. So kind of 72 hours as per guideline directed class 3. If within 12 hours is class 1 or 1.
So the risk versus benefit comes there.
So these are the case of having again. This is the anti-wall MI. LAD was totally occluded after the. This was the stent we are putting, and then after stenting, you look there at the junction of the diagonal and LAD. Perforated. Last week was showing using continuously leaking. We leave it patient shift to the ICU and see the hemodynamic. Then these are the level of effusion. Patient getting hemodynamic repeated. So immediately shift to cath lab and tapping pulses paradox with 300 effusion there. Very centuries. So check should be there and seal the vessel with cover. This is a pigtail catheter through the pericardium. So seal that perforation and make sure that patient is. This was a case we had done within half an hour. And again, last case, it is just this is kind of Phillips type 1, so we need to observe this 60 male unstable angina, RC was subtotal, we crossed the soft wire with balloon support, and at that time we felt that we crossing the false limit. This was the subtotal correction. So these are the showing myocardial blast at that time. So we didn't do anything. We put out of all the treatment and then again see the monitor of patient, echo and check angio. Nothing. This is a myocardial blast. It's not filling the pericardial cavity. So leave it alone. Didn't do any kind of intervention. So operation, it will if immediately we detect, immediately put a cover stent or distal embolization, it is a life-saving procedure if attend within a time period. Otherwise, large perforation didn't give you enough time. Enough time perforation, large vessel, main or bifurcating vessel, and lead to tamponade and adversity or morbidity, mortality. Thank you.
Perforation खबर